Okay, let's get started. Good morning, good afternoon, and good evening to anyone joining us today. My name is Alan Dominguez, and on behalf of the International Dysphagia Diet Standardization Initiative, I'd like to welcome you all to today's webinar titled Implementing IDDSI in Acute Care Settings, Sharing the Halton Healthcare Experience, presented by Marianne Katusin. It is my deep pleasure to also have with us IDDSI CEO and Chairperson Peter Lamb with us today, who will be moderating the Q&A period after Marianne's presentation. I just have some quick housekeeping to go through before I can hand it over. And I'll get started saying that the webinar is being recorded and will be available on the official IDDSI YouTube channel by the end of the week. Everyone attending the live session will be receiving a certificate of attendance automatically a couple hours after the session. You do not need to email us to receive the certificate. It'll arrive to the same email address that you used to register for this webinar. And lastly, but most importantly, we want to hear your questions throughout the presentation. So in your GoToWebinar panel, there is an option to submit your question. And while you be only in listen-only mode and the presenters won't be able to hear or see you during their presentation, we encourage you to submit your questions so that we can address them at the end of the session during our Q&A period. And that is all for me. So without further ado, I am going to introduce Peter Lamb into the session. Welcome, Peter.
Thank you very much, Alan. And thank you, everyone, for joining us today. I am thrilled to be able to have this privilege of introducing Marianne. I'll do that in just a moment. First of all, the warmest thank you and the most appreciative thank you to all of our IDDSI sponsors that you see on screen here. For those who may not have heard this message before, IDDSI is graciously supported by all these wonderful sponsors in an unconditional way. The sponsors have never and don't influence the work of IDDSI. The work of IDDSI is directed by a very, very wonderful board of directors, volunteer board of directors from all around the world. But we couldn't do the work that we do without these wonderful and generous sponsors. Alan, if you don't mind, advance the slide. We quickly want you to know that due to popularity, we are now making the effort to organize live in-person events all over the world. As you can see from this list here, the next event that's coming up is actually going to be in Miami, Florida, and also in the UK in September. So I'll quickly just tell you about the Miami event. It happens on June 5th and 6th. Hopefully some of you will have some kind of mobile device close by. Feel free to take a scan of that QR code that leads you to the registration for this event. We'll pop this up again at the end of the event. So exciting festival focusing on culinary and IDDSI, evidence-based toolbox, pediatrics, real-world challenges, and those of you working in the US particularly, there'll be a session on regulations. So we hope you can join us for this one. Next one, Alan, please. And then for those of you wanting to go to the United Kingdom, September 18th and 19th, lots of planning time ahead. We'll be in London, and this will be the fourth festival in the United Kingdom. And the focus this time around will be about a day in the life with dysphagia. There'll be patient caregiver experiences with IDDSI and food service and catering, IDDSI in clinical practice, as well as showcasing IDDSI innovations. So again, we'll pop these up towards the end so that if you didn't get a chance to capture the QR code, you can do so. You can also check out the registration and more information about the event on our website. www.iddsi.org. Okay. Let's get to our main event for the day. Marianne is an amazing supporter of IDDSI. Um, when I first met Marianne, she said to me, "Oh, I'd love to tell our story." And boy, oh boy, I was just joking with her, saying, "Oh yeah, now we're using and abusing you," because Marianne was kind enough to keynote at our Canadian IDDSI festival last fall. She's agreed to come and tell you more about the story of the Halton experience today. And then, backed by popular demand, Marianne's also going to be joining us in our Canadian IDDSI Festival later on this year in October in Toronto, Ontario. Um, Marianne is the Director of Support Services at Halton Healthcare. She has over 30 years of healthcare experience, and she did ask me to be kind, so I won't make any jokes about the over 30 years of experience. Um, she is certainly driven. She is innovative. She's committed to the whole patient meal experience. And in talking to Marianne, I can see that she's somebody that not only does her work technically, but she brings with her that incredible spirit of care. She's a foodie at heart, and nothing better than to have somebody who's a foodie in a position like this. Marianne has a Bachelor of Arts in Administration and Information Management. She also has a diploma in Food and Nutrition Management. And yeah, she currently also is a part-time instructor with the CHA Learning's Food Service and Nutrition Management program. And that's offered at Algonquin College Applied Arts and Technology. So, boy, oh boy, we couldn't have somebody more qualified to be talking about her experience in Halton Healthcare today. Without further ado, let me introduce you to Marianne. All yours, Marianne.
Thank you so much, Peter, for that lovely introduction. I am very, very happy to be able to present to a large number of people today and share some of our experiences at Halton Healthcare. So just in terms of a very quick agenda for the presentation, it should be about 30 minutes in length, and then there'll be some opportunity for some Q&A at the end. So I'm going to tell you a little bit about Halton Healthcare, who we are. We're going to talk a little bit about IDDSI and where it all began for our organization. We'll cover a little bit about education, product testing, and the menu development process. I will openly share with you the challenges that we experienced as part of our implementation process, some closing thoughts, and then some Q&As. So I am going to shut my camera off during the presentation just to make sure that we're not interrupted at any point. So, okay, so next slide, please, Alan. So just a little bit about who we are. So Halton Healthcare is located in the Halton area in Ontario. We are 3 community-based hospitals serving a growing urban and rural community of Halton Hills, Georgetown, Milton, and Oakville. We are part of Halton's rich history and have a long-standing tradition of providing quality care to many generations of families in our areas. Together, our 3 hospital sites serve approximately 500,000 residents. Next slide, please. So food services at Halton Healthcare operates at all 3 hospital locations. We have various meal delivery models, including our award-winning call-to-order room service model, which is available at all 3 of our sites. The Oakville Trafalgar Memorial Hospital is the largest of our 3 facilities, and this is our centralized production and procurement facility. So all items are prepared at our Oakville location, and we ship food 7 days per week to our Milton Hospital and to our Georgetown Hospital location. So those two sites are our receiver sites. We have a full production kitchen at the Oakville site. So we are very fortunate that we are able to produce a number of items in-house, which is not typically the norm in acute care facilities. We do recognize that. So we are producing some soups, some entrees, some texture modified items specifically to support the IDDSI requirements of our menus. We do utilize the Computrition software system in our hospitals, and it's integrated through our hospital system, which is Meditech Expanse. Our distributor partner is Gordon Food Service. Next slide, please. So where did we begin our IDDSI journey? So a couple of years ago, the hospital was undergoing a system upgrade. So this is the hospital information system. They were moving forward with a newer upgrade to Meditech Expanse. This was a perfect opportunity for us to be able to look at IDDSI and coincide some of the requirements at the same time as the system was being upgraded on the hospital side. So what that meant was we were able to create new diets, new textures, new nomenclature, and so forth on the hospital side at the same time that the upgrade was happening. Our current diets at that time were not compliant with the IDDSI guidelines, and several changes were required. So as I mentioned, this was an ideal time for us to really look at IDDSI implementation beyond the fluid level and really adopt some of the IDDSI guidelines and nomenclature into some of our policies and procedures and processes. Next slide, please. So the implementation process was probably a good 6 to 7 months for us. And that isn't just the system side of the implementation. We did a significant amount of collaboration with various partners in the facility. So our speech and language pathologists, our clinical nutrition and food services teams, our information systems teams, the clinical units, so the nurses, the physicians, and some of RDs. We did a significant amount of collaboration with each area to ensure that we were going to be compliant with the IDDSI guidelines. And in addition, that we were making sure that the system was being updated to meet the changes that we were making. So we ended up creating 2 brand new diets, the soft and bite-sized and the minced and moist. Those diets did not exist previously. We also took an opportunity to rename the fluid levels. So we were very much of the old school where everything was ordered in nectar, in honey, in pudding consistency. So what we decided to do was we were going to put in the levels. So level 1, 2, 3, 4, and so forth, and then put in the new nomenclature under the IDDSI requirements and guidelines. And then in brackets, we just kind of added the old nomenclature so people could become familiar with what we were doing, and it wasn't going to be, a lot of trial and error as they were creating new diet orders and so forth. The other significant thing that we needed to do was mapping into Computrition. So Computrition already existed, the software already existed. We were creating brand new diets, which meant that every ingredient, every recipe now had to be coded to the new diet. So restriction coding had to happen behind the scenes. The very first thing that we did on our road to implementation was the fluid testing. So that was the easiest thing for us to implement. The fluid piece was already readily available. We had lots of manufacturer partners that were already producing items in the various levels. So the juices and the milks, for example, were the easiest. The soups were a little more challenging because we do not thicken any product in-house. So we needed to make sure that we were going to be partnering with manufacturers who had done some testing of various soups and fluids that were going to meet the IDDSI level requirements. We did take a staggered approach to implementation because we figured that this was going to be a really overwhelming change for not only our organization at the clinical level, but also our frontline staff. So the fluid changes and the new nomenclature related to the fluids, we went live with that in September 2021, and then the new diets went live 2 months after that. Next slide, please. So as part of the implementation process, we also had to do some education, and that education involved education on the nursing units, and to our frontline staff. So this slide is a poster that we had developed as an introduction for our clinical units as part of their education. So what ended up happening is we started education on the units in August of 2021, and it was the clinical nutrition and food services team that took the show on the road. So we kept saying that we're taking our dog and pony show on the road and did the education. We were the experts. We were involved in, the implementation. We took this to all of the huddles on the units and explained the changes to them. We talked to them about what is IDDSI, what does IDDSI look like at Halton Healthcare? There's the patient safety component. We reviewed the IDDSI framework, and then we talked to them a little bit about the staggered approach and what they were going to see on their end and what the patients would see on their meal trays. So that was the education component on the units, which did take a couple of months because, again, we are tri-site, so we had staff supporting the education at each of the sites. Next slide, please. So the education in food services for our frontline staff, this was a little bit challenging as well. Not only did we do IDDSI kind of as a main topic at weekly staff huddles, we did one-on-one training with the frontline staff who were going to be doing meal assembly. It was very important for them to understand the differences in the consistency of the fluids and really understand what IDDSI meant and how it impacted our patients. So we reviewed the new framework. We developed posters and cheat sheets. You can see a little bit on this slide. We took photos of some of the products we were going to be using. We looked at sample labels that we reviewed with staff. We talked to them about the colors and the new verbiage that they were going to be seeing on various products. And a lot of them have really adapted this and taken well to it because now they, can recognize the fluids based on the color. And this is the way that it was the easiest for them to learn. We also took actual meal tickets printed from Computrition to show them what they were going to see during meal assembly periods on the tray ticket so that they could understand that what does L2 mean? What does L3 mean? And they could kind of make sense of that. Our biggest concern was that we were going to have, errors made on trays and that we would have, an issue or something come up and pose a patient safety risk to our patients. So we really, really took our time providing the education to the staff on the front line. And that included, like I said, the one-on-one training sessions in addition to the huddles. Next slide, please. So the implementation in terms of menu development, the very first thing after the fluid implementation, we took on the minced and moist diet implementation and menu development. This by far was the easiest for us to implement as several of our key manufacturer partners had already done their testing and product developing. Labeling was already ready. Like the minced proteins and entrees, we were purchasing those from our manufacturer partners because we do not produce any of those minced items in-house. They had already done that testing for us, so we knew what was suitable for this new minced and moist diet. And that's the reason we went live with that one immediately after the fluids. We then went on to tackle the soft and bite-sized diets, which we found out was very difficult. In order for us to provide a variety using outsourced products, because what we found was there was not a lot of products available to us in a ready-to-serve format. So in acute care settings, most hospitals are doing and purchasing items from manufacturers, and we are outsourcing. A lot of hospitals do not have the labor to be able to produce items in-house. So we worked with our distributor partner, Gordon Food Service, and several key manufacturers, like Maple Leaf Foods, for example, to source ready-to-serve proteins that would be suitable for the soft and bite-sized diets. So, for example, the diced chicken and the diced turkey, Maple Leaf has a wonderful product that meets the specification sizes for soft and bite-sized that we were able to easily add as a protein choice to our menus. We had to also do significant testing in-house. So we wanted to make sure that patients who were ordered the soft and bite-sized diet received relatively the same items that we were serving on our regular diet. So we started to experiment in-house with various casseroles that we had on our regular menu. So we went through and developed several recipes and procedures for creating the chopped beef lasagnas and other pastas, some of our, center of the plate proteins and so forth. We do have soft cooked vegetables. So we bring in diced vegetables in a frozen state. So carrots, turnips, squash, beets is a canned product that we're using. It's already soft enough, but we needed to develop a process and a procedure for our cooks so that they understood, what does soft cooked diced vegetable mean? So we went through a significant amount of testing and recipe development, engaged staff. We engaged our SLPs, our dietitians. We had patient and family advisors come in to do taste panels with us as we were going through this process while we were developing a suitable rotation to be able to serve the soft and bite-sized diet. Next slide, please. So further to that, the recipes and computrition had to be updated as well with exact procedures for our soft and bite-sized entree preparation. We wanted to make sure that our cook, we do have a cook on site at our Oakville site, who is producing these items for all three of our sites. So we needed to make sure that those procedures were exact in terms of, are we cutting manually? Are we utilizing equipment and so forth to prepare some of those items for the soft and bite-sized diets? And as I mentioned, we had multiple taste panels organized to ensure that we had compliance of the consistency and particulate size for this menu base. We were also very fortunate that we were able to have a frontline food service supervisor dedicated to working on IDDSI implementation with us. This was an absolute need for us because it wasn't something that we could do at the side of our desks or that I could ask some of my managers and supervisors to do in addition to their day-to-day tasks, because it involved a lot of sourcing, a lot of coding, a lot of testing and so forth. So we did have a dedicated resource to assist us through the implementation. And as I mentioned, SLPs, dietitians, nursing, our patient and family advisors were all included in some of the taste panels and so forth that we had provided, so they could provide their feedback and evaluation of the products. And more often than not, everything did seem to pass testing and evaluation, but we did have the odd entree that really didn't look that great once we had modified it. So we had to go back to the table and look at alternate products as well. Next slide, please. So some of the challenges that we experienced during our implementation, as I mentioned before, is there really isn't a lot of options for healthcare facilities who are outsourcing all menu items in a ready-to-serve format. There are lots of pureed entrees available, lots of minced entrees available, but there isn't the soft and bite-sized entrees and center of the plate proteins available for those facilities that don't have the labor to produce items in-house. The other piece that we found is the lack of skilled staff on site to support preparing some of these items. So what we saw was, as we were going through our testing phase and had different staff preparing the items, the particulate size varied depending on the staff working in the production areas. So what we found is that we really had to be detailed in our procedures and processes within the recipes to say, use knife to cut this beef patty, for example, and this is the way you're cutting it. We included diagrams and photos and so forth. And when they had to use, we purchased a chopper as well with the appropriate blades that allows staff to utilize that and cut items to the correct particulate. So that had to be incorporated into the procedure as well. The other challenge was it's the additional supervisory support to constantly review production of the soft and bite-sized items daily. So our supervisors are checking all of the items that our cooks are preparing to ensure that they meet the standards, they meet the particulate size, and so forth. So this does require a little bit of extra auditing on the supervisory side. The computrition update, so this is our food service system software, did require a significant amount of time to ensure all the 2 new diets were created and that every recipe was coded appropriately for the new diets. And we had, as I mentioned, lots of procedural updates for any of the in-house items that we were creating. Another challenge that we came across was with our manufacturer partners. There are still very few in the market who have a variety of items suitable for the soft and bite-sized diet. We wanted to try to, develop a suitable menu rotation with lots of variety and choice for our patients, but this was a stumbling block for us for any item that we were looking to purchase in a ready-to-serve format that was suitable for this diet. The other thing that we ran into was the supply issues at that time. We were all still dealing with post-pandemic recovery and supply issues. We had limited variety of items available, discontinued items, and so forth. So that was significantly a challenge for us. The other piece was the ongoing menu development. So we are still struggling through some of our therapeutic diets and meeting the needs of the patient population with soft and bite size, for example, and those that are vegan and or halal. We are seeing an increased number of patients come in with those diet orders, and we continue to see, the struggles that we have in terms of providing adequate proteins for the patients. The reality is you can only do so much with a veggie burger, for this patient population. And what we're starting to see is a veggie burger is not a culturally appropriate item for our patients that are coming in, for example, from a South Asian population where they are accustomed to a certain type of entree and a certain type of food variety. A veggie burger isn't going to cut it for, that vegan population. Next slide, please. So in terms of just some quick closing thoughts for those sites who are considering implementing beyond the fluid level at this point, my suggestion would be that you start small. Start with the fluids and then slowly progress through some of the other diets. Make sure you engage your key stakeholders. This is a huge component. You need to make sure that your speech and language pathologists are included, your dietitians, your physicians, your nursing, any of those key clinical folks on the units need to be engaged throughout the process, and continue to seek feedback, continue to get the feedback from your patients, from your patient and family advisors, from your frontline staff. They are a great source of information. They provide us lots of details about waste and plate waste audits and things that are, for items that are coming back to our dish room. We need to engage our manufacturer partners to develop more suitable items for healthcare facilities who do not have production kitchens or staff to support producing items in-house. As I mentioned, there is a lack of ready-to-serve items available for the soft and bite-sized diet specifically. Evaluation is key, and this needs to be done on a regular interval. We did lots of evaluation during our initial implementation, but we found that we had to continue to do patient satisfaction surveys on a regular basis, and we are getting a lot of positive feedback from patients, especially because if they happen to be, in a semi-private room where their partner might be getting a regular item, so a regular piece of beef lasagna, for example, and the patient next to them now can have the same item on a soft and bite-sized diet, it's just presented in a different format. Audits need to be conducted on a regular basis. We have supervisors conducting multiple audits monthly to ensure that the in-house items meet IDDSI guidelines. They are looking time and temperature audits and so forth. On a general level, the food service supervisors are doing at a minimum of 8 audits in the kitchen and on our patient units on a monthly basis. It is also very, very important that the ongoing education to the staff and periodic evaluation and refreshers are done with staff to re-educate, refresh, kind of ensure that they're following the policies and the procedures and the guidelines that are required. Anytime that we have, an incident perhaps that gets, entered by the unit, perhaps we've provided the wrong consistency, we always take that opportunity and turn that into an education moment for our staff to say, this is kind of what we've done incorrectly. Here's what we should have done. What do we need to support you to ensure that you're doing your position correctly and that you have the knowledge base behind you that you're serving the correct products during meal assembly. And the final thought that I have is change is not easy. I can assure you this change was not easy for anyone in our organization. It was a huge learning curve. But one of the things that we realized is with every challenge, there's an opportunity to elevate that patient experience, which we have been able to do through our IDDSI implementation. And the final slide, Alan. Thank you.
Thank you, Marianne. That was great. Nuggets of wisdom, packed full of information. Thank you for your leadership in taking the Halton state that it's in now with its implementation. I believe that we are now wanting to take some questions.
That's right, Peter. So for folks that are with us, please submit your questions using the questions button in your GoToWebinar panel, and Peter will be moderating, and hopefully we'll be able to answer all of those wonderful questions.
Thank you. We see your questions coming in. Please keep them coming. Marianne, you may have spoken about this already, but we have a question asking about whether or not you are producing most of the level 6 soft and bite size in-house now, and what are you currently doing?
Yes, so we are doing a combination of things. So we are bringing in some ready-to-serve products. As I mentioned, Maple Leaf Food Service has some great diced chicken and turkey products that we have tapped into as part of our center of the plate proteins in a ready-to-serve format. The other items we are producing in-house. So what we're doing is taking our finished regular product and modifying it either manually or utilizing the equipment that we've purchased to that soft and bite-sized format. We are purchasing all of the diced frozen vegetables, and then we do cook them in-house to make sure that they are that soft texture that they require. We have incorporated canned beets, diced beets, as well as a vegetable option. So we're doing a little bit of both. We do some in-house production, and then we also tap into bringing in some ready-to-serve items.
Great, thank you, Marianne. And along the lines of level 6 soft and bite size, there was a question about whether you'd be willing to share any examples of your level 6 soft and bite size menu items.
Absolutely. So I'm happy to I'm happy to share the menu with any of the attendees. Like I said, I'm all about sharing that knowledge. We're not here to reinvent the wheel. We're all in this together. So if there are sites that do want some samples or want to have a look at the menus, if they can email me, my email is on the screen. I'm happy to share that.
Great, thank you very much, Marianne. There was also a question about equipment.
Yes.
Yeah, any specific equipment, Not that we're trying to push any certain branding,
No,
but
and
if you can just
yep,
elaborate on
so
that, please.
I absolutely can. So we started out with, we had bought like a standard food processor to start this process, specifically for level 6 soft and bite size, and that was not cutting it out for us at all. We were not getting the right, particulate size or anything. So I'm not, I'm selling any product, but we purchased a Volrath. It's a machine that you can buy blades for, and the blade size that we bought is that 1 by 1 particulate size. So, for example, if I'm cutting up, let's say a beef burger, a fully cooked beef burger patty, I place the patty on top of that machine, and you just push down the wand, and it cuts it to the right particulate size. I can share those specs as well with anyone who is interested in looking at the piece of equipment. It is a bit of an investment. It is a couple of $100s. I'm not going to lie. And we did purchase a couple of extra blades for the unit as well, because we don't have, unfortunately, the opportunity to sharpen blades and so forth in-house. So if there are any attendees interested, again, reach out to me via email, and I'm happy to provide the specifications for that equipment.
Great, thank you. Marianne, I was told by the Canada IDDSI reference group that they're going to be pestering you and asking you for a very, very short interview for their next Canada IDDSI Can Do newsletter. So maybe we can capture some of that and have it available on the IDDSI website so that
Absolutely.
the entire world can access that information.
Yeah, absolutely. Like I said, we have some great manufacturers who, not only have equipment that's suitable that we may not have, used in other kind of applications, but when we started to do a little bit of research and so forth, it's amazing what you can actually find that is available out there.
Great. Yeah. Another question regarding collaboration with SLPs. Do they do the ongoing evaluation or is the evaluation done in the kitchen?
So the SLPs actually come down to the kitchen. So we invite our SLPs to all of our taste panels. So whether that be, new products that we're looking to introduce on our regular menus, on our vegan menus and so forth, or whether it's an item that we would like to incorporate on one of our IDDSI diets, whether it be minced and moist, whether it be, the soft and bite size. So the SLPs are very engaged and they do participate in our taste panels, which is fabulous for us because they really give us some good, feedback on, whether we could potentially include those items and whether we need to modify them to make them suitable for those diets. So they do bring a huge value to the evaluation process.
Great, thank you. And here's more of a, how to get started type question. How do we get our establishments on board with IDDSI? They've been told that it affects PDPM and billing. Can you share some wisdom on that?
So I'm not sure what the PM and billing piece is. I don't know if we can get a little bit of clarification on that part. But I guess it depends on the facility, whether it's long-term care or acute care as well. So in terms of starting IDDSI, like I said, the easiest thing is to start at the fluid level and bringing in some of the thickened fluids and things. That was the quickest and the easiest thing that we could do because we were, bringing in already thickened juices and thickened water and the thickened milk. Like most of the beverages we bring in from a thickened perspective. And then the next for us was these minced and moist. And again, as I mentioned in the presentation, we are not mincing anything in-house. We do bring in all of our minced entrees and proteins and vegetables and so forth. They are readily available for us. And because of the limited staff we do have, we made the decision that we would only produce the soft and bite-sized items in-house as we needed to, because we don't have that volume of labor at each of our sites to support that.
Great, thank you. There was a question about, do you serve more than one IDDSI level on a tray? And the example was what kind of soups would you be serving with minced and moist tray?
So if it was a minced and moist, just a minced and moist tray, we're typically serving them a strained cream soup. If it is a minced and moist with a need for thickened um, liquids, then it would depend on whether it was, L2 or L3 or whatever it happened to be. And that's the way we would serve that. So we do not thicken any soups in-house. We worked with manufacturer partners. So Campbell's, a number of their Eat Smart soups are suitable for L2, and Knorr. So Unilever Knorr has a couple of strained powder-based cream soups that are also suitable for level 3. And that's the way we kind of went down the route. So the short answer is yes, you can do that. So they could have just the straight minced and moist diet, or there could also be a need to have, fluids at an L2 or an L3 in combination with that.
Yeah. Um, Series of questions coming up. So one, do you serve and offer thickened oral nutrition supplements? And if so, can you comment? And yeah, let's do that one first.
Let's do that one first. So we don't thicken any of our supplements in the kitchen. We send the supplement up on the patient's tray with the appropriate thickener package, and they receive support on the unit level to thicken those supplements. And the reason we made that decision was strictly from a risk perspective, because we have, various staff rotating throughout positions and so forth, that it was easier to put, the supplement as is onto a patient tray with the thickener, and then they receive support on the unit, whether it be an SLP or a nurse and so forth. They would do the thickening on the unit level.
Okay, thank you. And then the next question was about the percentage of people that are on texture modified and using IDDSI textural levels. Can you either comment on the percentage or how many meals per day you are
Yep.
offering?
So the minced and moist diet is the one that we do serve the most of for our patient population. So out of the total kind of the IDDSI, I think it's probably about 15 or 16% are minced and moist. We are starting to see a lot more soft and bite size come in, either with or without the, the thick and fluid kind of requirement. So on average, at any given meal, it varies between about 40 to 60 patients across the 3 sites who require some type of either minced and moist or soft and bite size. The puree diet we've always had as well. So I would say it's probably about 15 to 20% of the patient population.
Okay, thank you. Um, and then there was a question about logistics with your 3 sites.
Yes.
Um, what is it that you're doing with production, and are things shared between the sites?
Yeah, so the Oakville site, which is the largest of the 3 sites, is our centralized production and procurement. And what we do is we send food in bulk from Oakville to our Milton and Georgetown hospital locations. They are receiver sites. We have partnered with a refrigerated transport company who picks up food from Oakville and takes it to the other sites 7 days a week, 365 days a year. And we send food in bulk. So that would be the soups and the entrees and any of the starches and the vegetables and so forth. The sites do have they carry a small inventory of, the juices and the milks and the crackers and the cookies and some of the desserts and things, but any of the entrees, the soups, the vegetables, the starches are all sent from Oakville, because we have a production area with a cook and with some production staff who are assembling these items to be sent to the 2 northern sites.
Okay, Thank you. Several questions have come in from attendees about do you actually serve two or more textural levels? And we're not talking about texture and thickness. We're just talking about textural level. Example, would you have a soft and bite-sized item on a plate, and then those are accompanied by minced and moist items?
Yes, we don't like to do that, but sometimes the order will come in where, there might be an order for, soft and bite-sized vegetables, but they need minced meat or minced protein. So we don't actually have a diet that exists like that. We have to do a lot of manipulation on the computation side to be able to allow those restricted items. But we do get those, on a rare occasion, not that often, but we do our best. And more often than not, I think it's, sometimes the SLPs as well are working with those patients in terms of, looking at swallowing and so forth. So they're kind of testing different things. So yes, we do get that request and order come through.
Yeah. And then there was a question here, the $1 million question. How do you handle breads and sandwiches in your locations?
So we don't serve bread on any of those diets. That was a decision that was kind of made here. So minced and moist, sometimes they will get a request for a crustless, sandwich with a minced and moist filling, and sometimes we'll have to send extra mayo on the side and so forth. But we don't often do sandwiches or serve breads to those diets. And like I said, that was an internal decision that was made.
Yeah. And there were a million questions that came in following your comment there. How have people reacted to the fact that you're not serving bread on the texture modifieds?
So I think it's a bit of a mixture of reaction. So it was an education component, I think, for our clinical units, and an education piece for patients as well. It wasn't the best reaction. Like I said, bread is something that is very much a staple for a number of patients, and they enjoy their sandwiches and so forth. So that we did not get a lot of positive feedback, but I think with the support of our dietitians and our SLPs in terms of doing some of that education on the units and explaining kind of the risks and the reasons for the omission, it certainly did help. It certainly did help us out. We do try to offer pureed breads as well as best as possible, whether it be as is pureed bread, which we mix in house, or a pureed bread pudding. We recognize that is not a substitute, but given kind of the guidelines and the guiding principles that were established, that was the best that we could do from an operations perspective.
Great, thank you. There were a couple of questions that have come in relating to costs. Since implementing IDDSI, what are you seeing in terms of the impact on your food costs?
So I think just in general, we've all seen an increase, in food cost, given the pressures and the inflationary pressures that we've all kind of experienced. So we try to, mimic as best as possible whatever we're serving on our regular diet. We do try to also serve that, on our soft and bite-sized diet. The minced items we were already bringing in a ready-to-serve format, so those were already costed in part of the budget. We have seen an increase, a slight increase, I think, in our fluid levels, because we do see an increased need for the thickened fluids at the various levels. And then, of course, there's contractual changes and things that happen as well, during the course of implementation and now post-implementation that we've had to do. So did our costs go up significantly as a result of IDDSI? No. Did they go up generally with all other food costs? Yes, they did.
Okay, and a fun one. Several people have written in and asked, um, would you be willing to take them for a tour through your
Absolutely.
production?
Absolutely. So we are always happy to, tour people. The Oakville Hospital is 1.6 million square feet. It is a very large facility. We often get groups, on site to look at our various meal delivery models, in particular our room service model of delivery. But we're very happy to bring groups on site to do any tours and kind of look at our, centralized, we have a centralized diet office as well that supports all three of our sites. We often have, folks coming in wanting to know a little bit more about CompuTrition and how we utilize the CompuTrition module. So I am very open to, to tours and hosting tours at any one of our sites. Just reach out to me on the email that's on screen, and I'm happy to work with you to arrange some time to come on site.
Yeah, it sounds like a great opportunity. Maybe a field trip needs to be organized, and
We love
uh,
field trips because we've been,
yeah.
sheltered for such a long time that we welcome, the opportunity to see people, and chat and network and kind of learn from each other.
Oh, fantastic, fantastic. Back to the question about room service orders.
Yes.
How do you manage that when it comes to IDDSI, texture modifieds?
Mhm. So we have a decentralized room service pantry. So it operates essentially as a little mini kitchen in our acute care tower, and all of the items are available in our just-in-time room service model as well. So a patient on a texture modified diet, one of the IDDSI diets, could come in and order room service meals. We have all of those items available for patients to select.
Great, Marianne. Thank you so much. There were several more questions around bread, and I think, Marianne, if you don't mind, I'll just jump in here by pointing people back to the IDDSI website. Uh, we have done a special feature on bread in the past for those who are still questioning about the safety of bread with texture modified foods. It really should be up to the discretion of the clinician doing the assessment, whether or
Mhm.
not the person has the ability to manage something like bread. We know
Mhm.
that there have been, multiple choking incidents and
Yeah.
even deaths as a result of people being given bread items, sandwiches when they don't have the ability to manage it. And so I'm just putting that plug in there. And I think we'll take one more question given the time here. Um, the question is, at the sites now, are you testing the food in the kitchen? And
Yes.
then is there testing also done at the bedside at the point of service?
Yes. So we did, during our initial implementation and testing, we did do that because we needed to follow the food item from the kitchen to the patient bedside to see whether there was going to be any changes to texture. Like, did it dry out? Did it change for some reason, as a part of reheat and serving? If it sat in a steam table for a period of time. So we did that significant testing during the implementation process. But our supervisors, as part of their audits that I had mentioned during the presentation, part of their 8 monthly audits, they are following the tray from the production point, from the assembly point to the end point, which is at patient bedside.
Great, thank you so much. And then I think if we can indulge you to really just sort of summarize and maybe share what are the top two things as people are either in the process of or some are just getting started.
Mhm.
What would you say the top two considerations are when people are starting or in the midst of their ITSE journey?
Yeah, so my thought would be, kind of look at what your overall goal is going to be. Are you looking to do, a full ITSE implementation all at once, which I mean, I wouldn't recommend just given the magnitude of, the implementation that is required. I would say definitely develop a bit of a project plan and a timeline and kind of, highlight those key goals. The other part of it, there's actually three things that I would say is education. I cannot stress enough how important education is, both at a frontline food service level, as well as education on your clinical units as well. And it's important that whether it's your clinical dietitians or your food services folks that are involved in that education, because there will be questions from those clinicians in terms of what kind of foods can I expect my patient to receive? And there needs to be somebody from the operational level who can, answer those pieces. And then it is testing, 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 and ensuring that you're documenting process, procedure, and then you're providing that, education back to your frontline staff. One of the things that I find is we can never educate enough, and we often now do. IDDSI has actually become part of our kind of annual curriculum in terms of we do a health and food safety focus at each of our huddles. We talk about IDDSI and do a bit of a refresher, because the reality is we've seen so many staff come and go, as most people in the food industry have. It's a great opportunity for us to be able to provide that education and refresher about the different levels, about the nomenclature, the colors, and why we provide the foods we do provide. So it's not an easy journey, and it's not something that can be done overnight. You have to give yourself adequate time. Like I said, it was a 6 to 8 month journey for us. And we started with the fluid level. So definitely give yourself enough time and make sure that, you're doing those checks and balances as you go, do your audits, document your processes, and complete that education.
Marianne, thank you. Thank you for sharing your wealth of wisdom with us and your experience of the whole IDDSI journey. Um, we can't thank you enough for having been in our festivals, as well as sharing this webinar. As mentioned earlier, Marianne's going to be at our Canada IDDSI Festival in October. We have another opportunity coming up next month for a webinar, and that is on May the 9th. It's on our IDDSI homepage. The webinar topic is Not Enough Cooks in the Kitchen, Sparking Team and Evidence-Based Implementation of IDDSI. It'll be shared by a wonderful team of folks from the United States. So please join us for that one. Register. It's on our website. And then again, just to mention the US Festival coming up, in-person festival on June 5th and 6th. Again, registration is available through our website, as well as the UK Festival, which is now also on our website. Alan, if you can back it up, just want to acknowledge our IDDSI sponsors one more time. Thank you for all the incredible support to help IDDSI continue to innovate and create possibilities. Thank you, everyone, for joining us today. We look forward to seeing you again at the next event. Marianne, thanks to you.
Thank you
Bye-bye.
so much. Bye-bye.